history, you know the clinical context, and you know that she's either at risk or she probably has a baby who is FGR. And you need to be very aware of the clinical context, the biochemical markers, which are not very popular, which are not very used this time, and of course ultrasound, which is the main focus of our talk. We will not talk about maternal risk factors because as gynecologists, I'm sure you know these better than I do. Just remember that infections are a cause of FGR, and any kind of infection can lead to that. So what are the ultrasound-based markers? You have dropping fetal growth, quad L, centiles, you have Dopplers, you have an abnormal uterine artery Doppler, you have an abnormal umbilical artery Doppler, you have an MCA which is abnormal, DV which is abnormal, Ductus Venosus which is abnormal. If you're really feeling very macho and gung-ho, you might try an aortic isthmus, and CPR, which is a very easy thing to derive, but probably is not used very often, as something that you need to think about. Placental anatomy, although we don't usually rely on placental anatomy to make this diagnosis, it does become important in certain conditions where the fetus might be predisposed to FGR or to other perinatal complications, and we will talk about those. And of course, reduced amniotic fluid is an independent marker of fetal unwellness. So with all of this data, we have two types of FGR. We have early FGR that happens before 32 weeks in a fetus that doesn't have congenital anomalies. It is defined as either an AC or an estimated fetal weight of less than third percentile, or an umbilical artery absent end diastolic flow, or you have an AC or EFV less than 10th percentile, which is combined with umbilical artery PI of more than 95th percentile, or a uterine artery PI of more than 95th percentile. You see, I'm not talking about absolute values here, and I'm going to demonstrate this in one of these slides. What might be normal at 26 weeks might not be normal at 32 weeks. So instead of using absolute term, PI should be less than 1.4 at every age, you should learn to correlate the values with the fetal age. And the way to do that is by using percentiles or standard deviations or Z-scores or something like that. And the next type of FGR is what happens after 32 weeks. Again, this can be an estimated fetal weight of less than third percentile, or 2 out of 3 of these following conditions. Weight of less than 10th percentile, or falling fetal growth velocity, which crosses 50 percentiles during your time of examination, or a CPR, which is abnormal, which is less than the 5th percentile, or an umbilical artery PI, which is more than the 95th percentile. Late FGR is a chronic condition. The fetus might have a normal weight. The umbilical artery might have a normal value, but still those fetuses are at an increased risk of stillbirth. So we will talk about this in some detail. So an early onset FGR has a prevalence of about 1%. You have severe placental disease and you have a very dramatic umbilical artery Doppler. I mean, this is the kind of thing that you usually diagnose, that is easy to diagnose. Say absent end diastolic flow, reverse end diastolic flow, that kind of thing. So this has a very high correlation with preeclampsia. It denotes severe hypoxia, systemic cardiovascular adaptation, and it has a high mortality and morbidity. And I'm sure all of you are aware of that. With late onset SGR, what might not be very obvious to you is actually more common than early onset FGR. This mild placental disease, umbilical artery Doppler can be normal. There is a low association with preeclampsia. There is mild hypoxia with cerebrovascular, cardiovascular adaptation, central cardiovascular adaptation, which means things are happening in the fetal brain. You have a lower mortality, but you have a higher incidence of stillbirth. Okay? So we need to be more sensitive to the possibility of a fetus that is normal size with normal umbilical artery, but still might have late onset FGR with diagnostic features that we will talk about. How do you do an ultrasound? Of course, you do your measurements. You do BPT, HC, AC, FL, you do your Dopplers, and if you are fortunate enough to have the lady come in twice, you can plot the profile, you can plot the growth, or you can plot how the Doppler has changed over time. I don't think I would be insulting your intelligence if I told you how to get a BPD, how to get an abdominal circumference, how to get a proper femur length, but some of you might still find this useful. And these are actually very good sections that have all of the geographical and anatomical marks that define a good section. So you have a good section for head circumference and BPD, you have a good section for abdominal circumference, and you have a good section for femur length. Growth charts. Now, I'm hoping that a lot of you are using growth charts. Okay? Some of you have growth charts in your machines. Some of you might have made photocopies of growth charts, but you must remember that not all growth charts are the same. That is especially true if you are using the WHO intergrowth chart. WHO had a worldwide multi-center trial to define growth charts, and Pakistan had Aga Khan University participate in that, and they derived a growth chart, and they said that everybody, the whole world's babies follow this kind of growth. It is actually a bit of a overstatement. Ideally, you should have your own growth charts. And fortunately, Kashif and I, in 2015 and 16, we analyzed 500 patients and derived our own growth charts for South Punjab, and we published it in 2017. Interestingly, when we superimposed these growth charts on Hadlock, we found that there was complete correspondence. So if you do not have access to our growth charts, you can continue to use Hadlock if that is what you're using, and be assured that these are pretty good in our population. Okay, growth velocity. I spoke about growth velocity. How do you get growth velocity? It is better to have certain dates. You should have two scans that are at least 3 weeks apart. Some people push it to 2 weeks, but I would prefer to have 3 or 4 weeks. You should measure AC and HC. इस पे बड़ी शिकायत है मुझे. A lot of people don't measure HC, a lot of people don't measure AC. These are very, very important parameters. HC, perhaps there was somebody who was saying that perhaps we should stop measuring BPD, because BPD can be affected by so many factors that are not really representative of fetal growth. You can have a compressed head, you can have a dolichocephalic head, you can have brachycephalic head, and that will just give you a spurious BPD result, but the HC in all of these patients is going to be more accurate. So you must do an HC, you must do an AC. And AC is a pretty difficult parameter to acquire accurately, and you need a lot of practice to do that. And you must remember that even if the fetus is appropriate for age, any small drop in growth velocity is associated with an increased risk of FGR. So not only must your fetus be growing, it should be growing as well as your growth slope that you already have in your charts is predicting. So if it is dropping, it's not good. So in this case, you see the orange diamonds, this is in normal range and this is still in normal range. If you hadn't done a growth velocity, you would not have realized that although the fetus is in normal range, the growth velocity has declined. So if you had done only one